Good evening, time traveler. Get comfortable, take a deep breath, and prepare for a journey into one of history's most disturbing professions. Tonight, we're going to experience what it was really like to be a doctor in medieval Europe, roughly from the 11th through the 15th centuries. But forget the images of wise healers curing the sick with herbs and skill, the learned physicians saving lives through knowledge, and the noble calling of medicine. That's not our story tonight. Our journey takes us into the sick rooms where bloodletting killed more patients than it saved, into the universities where medical students learned astrology instead of anatomy, into the plague wards where doctors wore bird-like masks filled with herbs while patients died by the thousands, and into the understanding that medieval medicine was less effective than doing nothing, and that most cures were actually causing harm. This isn't the sanitized version where doctors were heroes fighting disease. This is the reality, the humoral theory that was completely wrong, the treatments that tortured patients, the surgery performed without anesthesia or antiseptic technique, and the understanding that if you were sick in medieval Europe, seeing a doctor probably made you worse. Before we begin, leave me a comment telling me where you're listening from tonight. And if there's another historical topic you'd like me to explore, let me know. Your suggestions shape these journeys. Now, let's step into a medieval physician's practice and discover what medicine meant when the theory was wrong, the treatments were harmful, and the outcomes were usually fatal. If you were a medieval physician, and we need to distinguish between physicians, surgeons, and various other healers, you were a member of an elite profession that required university education and commanded respect, despite being almost completely ineffective at actually curing disease. The physician was a learned scholar who'd studied at universities like Salerno, Bologna, Paris, or Oxford, spending years learning medical theory based on ancient Greek and Roman texts. You read Hippocrates and Galen in Latin, studied the four humors, learned astrology and its relationship to medicine, and memorized elaborate classifications of diseases and treatments. You wore long robes, spoke in Latin medical terminology, and charged fees that only the wealthy could afford. But your actual medical knowledge was based on theories that were fundamentally wrong, and your treatments ranged from useless to actively harmful. The humoral theory that dominated medieval medicine was elegant, comprehensive, and completely incorrect. According to this theory inherited from ancient Greece, the body contained four humors: blood, phlegm, yellow bile, and black bile. Health resulted from proper balance of these humors, while disease was caused by imbalances. Each humor was associated with qualities: hot, cold, wet, dry, elements, air, water, fire, earth, seasons, and personality types. As a physician, you diagnosed illness by determining which humor was excessive or deficient, then prescribed treatments to restore balance. The theory seemed to explain everything: why people had different constitutions, why diseases varied by season, why treatment sometimes appeared to work. The problem was that the humors didn't actually exist as described, so the entire theoretical framework was fiction. The diagnostic methods you used as medieval physician included examining urine, taking pulse, and inspecting tongue and other visible signs. Uroscopy, examining urine's color, smell, consistency, and even taste, was considered essential diagnostic tool. You had elaborate charts showing dozens of urine colors and what they supposedly indicated about humoral imbalances and disease. You examined urine in glass flasks, holding them up to light, swirling them, and pronouncing diagnoses based on whether the urine was cloudy, clear, red, yellow, or any of numerous other variations. The urine examination was often performed without even seeing the patient. Patients would send urine samples to physicians who diagnosed based solely on the urine. This created opportunity for fraud and error, but was considered scientifically legitimate. The treatments that humoral theory prescribed were designed to rebalance humors through various means. Bloodletting was most common treatment, removing blood to reduce the sanguine humor. Purging through laxatives expelled yellow bile. Inducing vomiting removed phlegm. Sweating, urination, and other expulsions were all methods of removing excess humors. The treatments shared common feature. They all weakened the patient by removing blood, fluids, or nutrients. A patient with fever might be bled until they fainted, given powerful laxatives until they were dehydrated, and prescribed fasting to reduce their strength further. These treatments often killed patients who might have survived with rest and proper nutrition. The bloodletting that you performed as physician was done in multiple ways. Venesection involved opening a vein with a lancet and allowing blood to flow into a bowl. The amount removed varied, but could be substantial, a pint or more. The timing and location of bloodletting was determined by astrology and humoral theory. Certain veins were opened for certain conditions, and bleeding during specific moon phases was considered more effective. Cupping involved placing heated cups on skin to draw blood to the surface or to draw it out through small cuts. Leeches were applied to draw blood from specific locations. The bloodletting was supposed to remove corrupt blood and rebalance humors, but it actually weakened patients and reduced their ability to fight disease. The pharmaceutical treatments that medieval physicians prescribed were mixtures of herbs, minerals, and animal products based on humoral theory and doctrine of signatures. The doctrine of signatures held that plants resembling body parts would treat those parts. Walnuts resembled brains, so treated head ailments. Yellow flowers treated jaundice. The pharmacopoeia included both genuinely useful herbs, willow bark containing aspirin-like compounds, digitalis for heart conditions, and completely useless or toxic substances. The prescriptions were elaborate mixtures of dozens of ingredients, each supposedly contributing specific qualities to rebalance humors. The complexity made it impossible to determine what actually worked. If the patient improved, every ingredient in the 40-component mixture might receive credit. The theriac, that was considered miracle cure-all, was an elaborate mixture containing dozens or even hundreds of ingredients, including opium, various herbs, honey, wine, and supposedly viper flesh. The recipe was closely guarded secret, and the preparation took months or years. Theriac was expensive and prescribed for almost every ailment. It probably had some effect due to opium content, but was mostly placebo with price tag that only wealthy could afford. The theriac represented medieval medicine at its most elaborate and least effective. Enormous complexity producing minimal benefit. The surgery that existed in medieval period was separate profession from medicine and was considered lower status manual work. Surgeons were craftsmen who learned through apprenticeship rather than university education. They set broken bones, treated wounds, removed bladder stones, performed amputations, and cut for cataracts. The surgery was performed without anesthesia beyond alcohol or opium, without antiseptic technique, germ theory didn't exist, and with crude instruments. The mortality rate from surgery was high, perhaps 50% or more for major procedures. Infection killed most surgery survivors, but surgeons occasionally succeeded and developed practical anatomical knowledge that physicians lacked. The barber surgeons who performed most actual surgical work were hybrid profession, combining hair cutting, shaving, and minor surgery. They pulled teeth, lanced boils, set bones, and performed bloodletting for physicians who considered hands-on bleeding beneath their dignity. The barber surgeon's red and white striped pole represented blood and bandages from their bloodletting practice. They had practical skills, but limited theoretical knowledge. Their social status was below physicians, but their actual effectiveness was probably higher because they dealt with conditions, wounds, fractures, abscesses, where intervention could help. Unlike physicians treating diseases they didn't understand with harmful treatments, the plague that devastated Europe from 1347 onward revealed how utterly helpless medieval medicine was against epidemic disease. The Black Death killed perhaps a third of Europe's population, 30 to 60 million people, and medieval physicians had no effective response. The plague doctors who treated victims wore protective clothing, including the famous bird-beak masks filled with herbs, which did nothing to prevent infection. The treatments they prescribed, bloodletting, purging, avoiding bad air, were useless or harmful. The physicians couldn't explain the disease, though some correctly identified contagion as factor, couldn't prevent it, and couldn't cure it. The mortality rate for plague patients was perhaps 50 to 80% regardless of treatment. The physicians who treated plague often contracted it themselves and died, though some survived possibly through luck or previous exposure, providing immunity. The plague treatises that physicians wrote attempting to explain and treat the disease show medieval medical reasoning at work. They attributed plague to corrupted air, miasma, unfavorable astrological configurations, God's punishment for sin, or various combinations of the recommended preventatives included avoiding bad smells, burning aromatic woods, carrying pomanders filled with spices, and fleeing infected areas, the last being actually effective advice, though for wrong reasons, were standard medieval medicine, bloodletting, purging, theriac, applied to disease they didn't understand. The treatises are historically valuable as documents of medieval medical thought, but therapeutically they were worthless. The anatomical knowledge that medieval physicians possessed was limited and often wrong because human dissection was restricted. The Church didn't absolutely forbid dissection, but made it difficult and irregular. Universities occasionally performed public anatomical demonstrations where a professor read from Galen while a barber surgeon dissected a criminal's corpse. But these were rare events, perhaps 1 or 2 per year, and were treated as rituals confirming ancient texts rather than investigations to discover new knowledge. When the dissection revealed structures that contradicted Galen, the discrepancy was explained as human degeneration since classical times, rather than error in the ancient text. Your anatomical knowledge as physician came from reading Galen and Arabic medical texts, not from examining actual bodies. The medical education that produced physicians took years and cost fortunes, limiting the profession to sons of wealthy families or those sponsored by church or noble patrons. You began with preparatory studies in Latin, grammar, logic, and rhetoric. Then came medical faculty, where you spent 6, 7 years studying medical texts, attending lectures, and participating in disputations. The curriculum emphasized theoretical knowledge over practical skill. You read Hippocratic Corpus, Galen's works, Avicenna's Canon of Medicine, and various other classical and Arabic texts. You learned humoral theory, astrological medicine, and elaborate classifications of diseases. You didn't examine patients, perform surgery, or do anything hands-on that was beneath physicians' dignity. When you finally graduated with doctorate in medicine, you could diagnose and prescribe treatments, but had never touched a sick person. The licensing that regulated medical practice varied by location, but generally required university degree for physicians. The physician's license was valuable monopoly. In many cities, only licensed physicians could practice internal medicine and charge professional fees. Unlicensed healers who treated the sick could be prosecuted. But enforcement was inconsistent, and the majority of medical care was provided by unlicensed practitioners because licensed physicians were too expensive and too rare. A major city might have a dozen licensed physicians serving population of $50,000, clearly inadequate, so most people received care from apothecaries, wise women, folk healers, or religious institutions. The fees that physicians charged were substantial and excluded most of the population from their services. A physician's consultation might cost several days' wages for a laborer. Treatment courses could cost months of income. The wealthy paid for elaborate prescriptions involving expensive ingredients, multiple visits, and ongoing care. The poor couldn't afford physicians and relied on charity care from monasteries or cheap services from unlicensed healers. This created a two-tier system where wealthy received elaborate but ineffective care from educated physicians, while the poor received simple care from practitioners who might actually be more effective because they used fewer harmful treatments. The competition between different types of healers created tensions and turf battles. Physicians claimed monopoly on internal medicine based on their university education. Surgeons claimed monopoly on manual interventions. Apothecaries prepared medicines but weren't supposed to diagnose. Midwives delivered babies and treated women's conditions. Wise women, herbalists, and folk healers treated common ailments using traditional remedies. Each group defended its prerogatives against encroachment by others. The physicians, being most educated and politically connected, generally won these battles, securing legal privileges even though their actual effectiveness was questionable. The women who practiced medicine faced significant barriers. Medical universities didn't admit women, so they couldn't become licensed physicians. Women worked as midwives, wise women, and folk healers, using practical knowledge passed through oral tradition. Some women became quite skilled and respected within their communities, but they were vulnerable to accusations of witchcraft, especially if their patients died, or if they had conflicts with male physicians. The witch hunts that intensified in late medieval and early modern periods targeted female healers disproportionately, killing many experienced practitioners and reinforcing male monopoly on legitimate medicine. The midwifery that was exclusively female domain represented area where practical experience mattered more than theoretical knowledge. Midwives assisted at births, handled complications, and cared for newborns. They learned through apprenticeship and experience. The maternal mortality rate was perhaps 1 to 2% per birth, which meant that over multiple pregnancies, many women died in childbirth. Infant mortality was 20 to 30%. Midwives could do little beyond providing comfort and managing normal deliveries. When complications occurred, breech births, obstructed labor, hemorrhaging, the outcomes were usually fatal for mother, infant, or both. Male physicians generally didn't attend births unless called for desperate situations, and their interventions, bloodletting mostly, probably made things worse. The hospitals that existed in medieval period were primarily religious institutions focused on care rather than cure. Monasteries and religious orders operated hospitals, hospitales, that provided food, shelter, and basic care for the sick poor. The care was custodial, clean bedding, adequate food, prayers, rather than medical in modern sense. Physicians rarely visited hospital patients. The mortality rate in hospitals was high, partly because they admitted people who were already dying. But the hospitals provided valuable social service for those with nowhere else to go. The specialized hospitals for leprosy, lazar houses, isolated lepers from society, providing minimal care while preventing disease spread. Effective public health measure, though cruel to patients. The leprosy that medieval Europeans feared and isolated was actually a mix of true leprosy, Hansen's disease, and various other skin conditions. The diagnosis was made by examining skin lesions, and many people labeled lepers probably had other diseases. Confirmed lepers were legally dead. They lost property rights, couldn't marry, and were excluded from society. They lived in lazar houses or wandered as outcasts, required to announce their presence with bells or clappers. The treatment was ineffective. Physicians prescribed traditional remedies, but leprosy was chronic and progressive. The isolation of lepers was a public health measure that probably did reduce disease transmission, though at enormous human cost. The public health measures that medieval authorities implemented show some practical understanding despite theoretical ignorance. During plague outbreaks, cities implemented quarantines, isolating travelers from infected areas for 40 days. 40 giorni, hence quarantine. They cleaned streets, banned certain activities, and buried plague dead quickly. These measures had some effectiveness despite being based on miasma theory, rather than understanding of bacterial transmission. The sanitation regulations that some cities enforced, requiring waste disposal, prohibiting certain noxious industries within city walls, improved conditions, even though the theoretical justification was wrong. The specific diseases that medieval physicians confronted included many that are now preventable or curable, but were then death sentences. Smallpox killed children and adults, leaving survivors scarred and sometimes blind. Tuberculosis, consumption, was chronic wasting disease that killed slowly. Dysentery and typhoid from contaminated water killed thousands. Puerperal fever killed new mothers from infections. Ergotism from fungal contamination of grain caused convulsions, hallucinations, and gangrene. The physicians recognized these diseases as distinct conditions, but couldn't treat them effectively. The mortality rates were high, and the suffering was prolonged. The specific example of treating a fever shows medieval medicine in practice. If you presented to physician with fever, they'd examine your urine, take your pulse, inspect your tongue, and possibly consult astrological charts based on your birth date and the current planetary positions. They diagnose an excess of yellow bile, cholera, causing the fever. The prescribed treatment would include bloodletting to reduce the heat, purging with laxatives to expel the excess bile, dietary restrictions to avoid foods that increased heat, meat, wine, spices, and possibly theriac or other pharmaceutical preparations. You'd be told to rest in darkened room to avoid stimulation. The treatment would weaken you significantly, possibly fatally, if the fever was from serious illness. If you survived, it was despite the treatment, not because of it. If you died, the physician would explain that the disease was too advanced or that God had called you home. The pain management that medieval medicine offered was limited. Opium derivatives provided some relief and were prescribed for severe pain, though addiction was a recognized problem. Alcohol was used as anesthetic before surgery and analgesic for chronic pain. Herbal remedies included mandrake, hemlock, and henbane, which had sedative and pain-relieving properties, but were dangerous in wrong doses. For most people suffering chronic pain from arthritis, injuries, dental problems, the options were endurance, prayer, or dangerous drugs. The suffering that modern pain management prevents was simply accepted as unavoidable part of life. The dentistry that existed was crude extraction. Toothaches were common from poor dental hygiene and sugar consumption among wealthy. The treatment was extraction using primitive forceps, performed by barber surgeons or traveling tooth drawers. There was no anesthesia, no antibiotics for subsequent infections, and no understanding of how to prevent tooth decay. Many people lost most teeth by middle age, affecting nutrition, appearance, and speech. Dental abscesses could be fatal if infections spread. The toothworm theory, that tooth decay was caused by worms boring into teeth, was widely believed despite being completely false. The astrology that was integral to medieval medicine was considered scientific knowledge, not superstition. Physicians learned astrological medicine as part of their training. The positions of planets and stars were believed to influence health and disease. The moon's phases affected when to perform bloodletting or surgery. A person's birth chart influenced their constitution and susceptibility to diseases. Certain days were more auspicious for treatments than others. Physicians consulted astrological almanacs before prescribing treatments. From modern perspective, this was complete nonsense. But medieval physicians genuinely believed in astrological influences and made treatment decisions based on celestial observations. The alchemy that some physicians practiced sought to create medicines through chemical processes. The search for elixir of life or philosopher's stone that could cure all diseases and grant immortality was serious scientific pursuit. Alchemists experimented with distillation, heating, mixing various substances seeking transformative powers. Some alchemical preparations contained mercury, lead, and other toxic metals that poisoned patients. But alchemy also developed practical chemical knowledge and laboratory techniques that eventually contributed to modern chemistry and pharmacology. The boundary between alchemy and practical pharmaceutical preparation was blurred. The wound treatment that surgeons provided was area where medieval medicine occasionally succeeded. Clean wounds were washed, sometimes with wine, which had antiseptic properties, though this wasn't understood, and bandaged. Severe bleeding was controlled with cautery, burning vessels shut with hot irons, which was agonizingly painful but effective. Fractures were set and splinted. These practical interventions sometimes worked, and soldiers and accident victims could survive with proper care. But any wound that became infected was likely fatal. The pus that formed in wounds was thought to be healthy sign of healing, laudable pus. So physicians didn't try to prevent infection, but actually promoted suppuration. The trepanation that was performed for head injuries, seizures, and headaches involved drilling holes in the skull to relieve pressure or release evil spirits. Archaeological evidence shows many trepanned skulls, some with signs of healing, indicating the patient survived the procedure. Trepanation was performed without anesthesia, using drills or scrapers. The survival rate was probably around 50%. Some patients may have been helped if they had conditions like subdural hematomas that needed drainage, but most trepanations were based on incorrect theories and likely did more harm than good. The fact that many patients survived trepanation shows human resilience more than surgical skill. The cautery that was used to treat wounds, tumors, and various diseases involved burning tissue with hot irons or caustic chemicals. The theory was that burning would cleanse wounds and remove diseased tissue. The practice was excruciatingly painful and often caused severe scarring and disability. Cautery was used for hemorrhoids, tumors, ulcers, and to remove tissue. The burning destroyed tissue, but also killed infectious organisms, so sometimes had beneficial effects by accident. But the suffering it caused and the scarring it left made it one of medieval medicine's crueler practices. The cataract surgery that couching involved was one procedure where medieval surgeons could genuinely help. Cataracts caused progressive blindness as lens clouded. The couching procedure involved inserting needle into eye and pushing the clouded lens backward, allowing light to reach retina again. The vision was never normal afterward, but was better than being blind. The procedure was performed without anesthesia, while patient was held immobile. The risk of infection, hemorrhage, or blindness was high, but the potential benefit made it worthwhile for those desperate to see. The cataract couchers were specialists who traveled between communities performing this procedure. The bladder stone surgery, that lithotomy involved cutting into bladder to remove stones that caused excruciating pain and urinary obstruction. The surgery was performed through perineum without anesthesia. The patient was restrained while surgeon cut tissues, located stone by feel, and extracted it. The mortality rate was perhaps 50% from shock, bleeding, or subsequent infection. But the alternative was slow death from urinary obstruction, so desperate patients underwent the procedure. Successful lithotomy was celebrated, and successful practitioners could make significant income from this specialized surgery. The amputation that was performed for severely injured or gangrenous limbs was major surgery with high mortality. The limb was sawed off using carpenter's saw, blood vessels were cauterized or tied off, and the stump was bandaged. Without anesthesia, the patient experienced unimaginable pain. Many died from shock during the procedure. Of those who survived amputation, many died from subsequent infection. The amputees who survived faced disability and social stigma. Prosthetic limbs existed, but were crude. Amputation was last resort performed only when gangrene threatened life, and the decision was often delayed too long, reducing survival chances. The university medical curriculum that trained physicians was heavily theoretical and based on reading ancient texts rather than observation. Medical students attended lectures where professors read and commented on Galen or Avicenna. They participated in disputations where they debated abstract medical questions. They studied logic and natural philosophy as foundation for medical theory. They learned astrological medicine, humoral theory, and elaborate classifications of diseases. They rarely or never examined actual patients during their training. When they graduated, they knew extensive theoretical framework, but had no practical clinical experience. The apprenticeship system that trained surgeons actually produced more useful knowledge despite lower prestige. The Arabic medicine that medieval European physicians learned from was more advanced than contemporary European practice. The Islamic world had preserved and extended Greek medical knowledge, adding observations and treatments from Indian and Persian medicine. Physicians like Avicenna, Ibn Sina, and Rhazes al-Rasi wrote comprehensive medical texts that were translated into Latin and became standard textbooks in European medical schools. The Canon of Medicine by Avicenna was used as primary medical text in Europe for centuries. Arabic physicians made advances in pharmaceutical preparation, surgery, and clinical observation that European medicine slowly absorbed. But even Arabic medicine was limited by same fundamental problems: incorrect theory and lack of understanding of disease mechanisms. The cauterization points that medieval texts specified for various diseases were based on elaborate theories about where burning would cure specific conditions. Different points on the body were cauterized for different diseases. The Cautery maps showed dozens of points where hot iron should be applied. The Cautery was supposed to draw out disease, alter humoral balance, or otherwise cure illness. In reality, it created painful burns that could become infected and cause additional problems. The elaboration of Cautery theory shows how medieval medicine could build extensive practical systems on completely wrong theoretical foundations. The dietetics that medieval physicians prescribed was area where their advice was sometimes helpful, despite wrong theory. They recommended moderate eating, avoiding overindulgence, balancing hot and cold foods, and adjusting diet to season and individual constitution. Some of this advice, moderation, varied diet, was genuinely healthy. The theoretical justification was wrong, humoral balance, but the practical outcome could be beneficial. The dietary restrictions for sick people, light foods, avoiding meat, plenty of fluids, accidentally helped by reducing digestive burden and maintaining hydration. Even when the why was wrong, the what could occasionally be right. The regimen that physicians prescribed included diet, exercise, sleep, and bathing habits tailored to individual constitution and seasonal variations. The advice to exercise moderately, maintain regular sleep, and bathe occasionally was sensible health guidance. The elaborate humoral justifications were nonsense, but the practical recommendations promoted healthy habits. The wealthy patients who could afford physicians and follow elaborate regimens probably benefited slightly from structured, healthy lifestyle, even though the theoretical medicine was worthless. The poor who couldn't afford physicians but maintained active lifestyles and simple diets were probably healthier despite receiving no medical care. The pregnancy and childbirth care was handled primarily by midwives with minimal physician involvement. Physicians generally didn't examine pregnant women and attended births only if called for complications. The care during pregnancy was basic: dietary advice, avoiding strenuous activity, prayers for safe delivery. The childbirth was managed by midwives who used practical knowledge passed through oral tradition. They knew positions that facilitated delivery, techniques to control bleeding, and basic newborn care. The maternal and infant mortality rates were high by modern standards, but midwives' practical experience was more valuable than physicians' theoretical medicine. When physicians did intervene in difficult births, their bloodletting and other treatments probably increased mortality. The mental illness treatment in medieval period was mix of religious, medical, and punitive approaches. Severe mental illness might be attributed to demonic possession, requiring exorcism. Melancholy, depression, was explained as excess black bile and treated with bloodletting and purging. Mania was thought to be excess yellow bile requiring cooling treatments. The treatments were ineffective and sometimes cruel. Some mentally ill people were cared for by families or religious institutions. Others were imprisoned or mistreated. The understanding of mental illness was entirely wrong, and the treatments ranged from useless to abusive. The kindest treatment was probably care in monasteries that provided shelter and routine without attempting medical intervention. The saints and relics that people sought for healing represented alternative to medical treatment. Pilgrimage to saints' shrines seeking miraculous cure was common practice. The sick would travel to shrines, pray, touch relics, and hope for divine intervention. Sometimes people reported miraculous cures, whether through genuine psychosomatic effects, spontaneous remission, or fraud. The Church promoted saints' healing powers as documented miracles. For many people, seeking saintly intervention was more affordable and offered more hope than physicians' treatments. The fact that miraculous healing succeeded no more often than physicians' treatments didn't reduce its appeal. Both were essentially ineffective, but saints were cheaper and didn't weaken you with bloodletting. The Jewish physicians who practiced in medieval Europe often had better medical training and knowledge than Christian counterparts, because they maintained connections to Arabic medical tradition and studied medical texts in original languages. Jewish physicians served Christian patients, including nobles and royalty, despite religious discrimination. They were valued for their knowledge, but faced suspicion and accusations during crises. Jewish physicians were blamed for plague and other disasters. The presence of successful Jewish physicians created resentment among Christian medical practitioners who had them expelled from various cities and kingdoms. The medical excellence that some Jewish physicians achieved was despite, not because of, the discrimination they faced. The bedside manner that physicians cultivated was an important part of their practice. You maintained dignified bearing, spoke in learned Latin phrases, and projected confidence in your diagnoses and treatments. The elaborate rituals, urine examination, pulse-taking astrological consultation, reassured patients that thorough expert analysis was being performed. The expensive prescriptions demonstrated that powerful medicines were being deployed. The physician's confidence and ritual reassurance had placebo effects that sometimes helped patients feel better even when the treatment was physiologically useless or harmful. The bedside manner was a professional asset that commanded fees even when actual medical effectiveness was minimal. The income that successful physicians earned could be substantial. A university-trained physician serving wealthy clients or employed by city or noble patron could make hundreds of florins annually, enough to live comfortably. The most successful court physicians accumulated significant wealth, but most physicians struggled financially because competition was intense in cities and wealthy patients were limited. The physicians who served small towns or rural areas made modest incomes comparable to skilled craftsmen. The investment in medical education was expensive, and the financial returns were uncertain unless you secured wealthy patrons or lucrative city appointments. The plague doctors who treated epidemic victims during outbreaks were often second-rate physicians who couldn't find better employment or were specifically hired by cities desperate for anyone willing to treat the sick. They received special payments and sometimes protection from prosecution for malpractice. They wore protective clothing, long leather or waxed canvas coats, gloves, and the famous bird-beak masks filled with aromatic herbs supposed to purify the air they breathed. The costume offered no actual protection against plague bacteria transmitted by flea bites, but the doctors didn't know this. Many plague doctors contracted plague and died. Those who survived probably did so through luck or prior exposure rather than their protective measures. The malpractice that physicians committed was difficult to prosecute because determining whether bad outcomes resulted from poor practice or inevitable disease was impossible given the state of medical knowledge. Physicians who clearly deviated from standard practice could be sued or prosecuted, but the standard practice itself was largely ineffective, so even competent physicians killed many patients through accepted treatments. The rare malpractice cases usually involved clear fraud, charging for treatments not provided, claiming credentials not possessed, or results so disastrous that even medieval standards recognized them as negligent. The lack of accountability meant incompetent physicians could practice for years before being stopped. The guild organization that physicians formed in some cities regulated the profession, controlled admission, and protected members from competition. The medical guilds set fees, prosecuted unlicensed practitioners, and maintained professional standards. They also restricted innovation and competition, defending traditional practices even when ineffective. The guild structure benefited established physicians by limiting supply and maintaining high fees, but it didn't improve medical care or outcomes. The guilds were more interested in professional status and economic protection than in actually healing patients. The anatomical illustrations in medical texts were often inaccurate or highly stylized. Since dissection was rare and the primary goal was confirming ancient texts rather than discovering new anatomy, the illustrations reproduced errors from older sources. The diagrams of humoral flows, zodiacal correspondences, and cautery points were elaborate but represented non-existent physiological processes. The few illustrations based on actual dissections were more accurate, but still limited by artistic conventions and theoretical preconceptions. Medical students learned anatomy from these flawed illustrations and from reading texts, not from examining bodies. The specific example of a physician treating a plague patient shows medieval medicine confronting disease it couldn't understand or treat. When called to treat plague victim, you would examine the patient from distance. Plague doctors learned to avoid close contact, observe the buboes, swollen lymph nodes, check pulse and urine if possible. You'd diagnose corrupt air causing humoral imbalance. The prescribed treatment would be bloodletting despite the patient already being in shock, purging to clear toxins, and theriac or other expensive medicines. You'd recommend burning aromatic herbs to purify air and might lance the buboes to drain them. All of these treatments were useless or harmful. The patient would likely die regardless of treatment. If they survived, it was their immune system saving them despite your interventions, not because of them. The transition from medieval to early modern medicine began in the Renaissance, with increased emphasis on observation and anatomy. Andreas Vesalius's publication of De Humani Corporis Fabrica in 1543, based on extensive human dissection, corrected many anatomical errors and established empirical observation as superior to ancient texts. But the theoretical framework remained largely humoral until the 17th and 18th centuries, when new understanding of circulation, respiration, and chemical processes began replacing ancient theories. The transition was gradual, and many medieval practices persisted well into early modern period. Bloodletting continued as common treatment into the 19th century, despite its ineffectiveness. The comparison between medieval European medicine and other contemporary medical traditions shows that the problems weren't unique to Europe. Chinese medicine had different theoretical framework, qi, yin-yang, 5 elements, that was also wrong, but produced different treatments. Islamic medicine was similar to European because both derived from Greek sources, but had some advances in pharmaceuticals and surgery. Indian Ayurvedic medicine had its own incorrect theories and treatments. All pre-modern medical systems suffered from fundamental ignorance of disease mechanisms, anatomy, and physiology. The specific errors varied, but the inability to effectively treat most diseases was universal. The rare successes that medieval medicine achieved should be acknowledged despite the overall ineffectiveness. Some herbal remedies worked: willow bark for pain, digitalis for heart conditions, cinchona bark, later, for malaria. The practical wound care that surgeons provided saved some trauma victims. The public health measures during epidemics reduced disease transmission. The midwives' practical knowledge enabled successful deliveries in normal cases. But these limited successes didn't outweigh the vast harm done by standard medical practices: bloodletting, purging, toxic medications, and erroneous theory that delayed real medical progress for centuries. The ethical questions about medieval physicians' responsibility for harm they caused have complex answers. The physicians genuinely believed in humoral theory and thought they were helping patients. They followed accepted medical knowledge of their time. They couldn't be expected to discover modern medicine through pure reason. From their perspective, they were learned professionals doing their best with available knowledge. But from modern perspective, they were causing enormous harm through practices that simple observation should have revealed as ineffective. The thousands of patients weakened or killed by bloodletting, the surgical patients who died from infections that basic hygiene could have prevented, these harms were real even if the physicians didn't understand what they were doing. The alternative healers who practiced outside the physician-dominated medical system sometimes provided better care because they used simpler treatments. The wise woman who prescribed herbal tea and rest for fever wasn't weakening the patient with bloodletting and purging. The village healer who bound wounds cleanly and let them heal naturally achieved better results than physicians who probed wounds with dirty instruments. Laudable. The midwife who let birth proceed naturally usually got better outcomes than the physician who intervened with aggressive treatments. The irony was that expensive elite medicine was often worse than cheap folk healing, though both were limited by fundamental ignorance of disease. The medical manuscripts that preserved and transmitted medical knowledge were copied by hand until the printing press arrived in the 15th century. The manuscripts contained texts from ancient authors, Arabic physicians, and contemporary medical writers. The copying introduced errors that accumulated over centuries. Marginal notes and commentaries were sometimes incorporated into main text. The result was that medical texts became increasingly corrupted versions of already flawed sources. The arrival of printing allowed more accurate reproduction and wider distribution of texts, though it also perpetuated errors more widely. The printed medical texts of early modern period still contained much medieval medical theory and practice. The medical instruments that physicians and surgeons used were relatively simple. Surgeons had scalpels, saws, forceps, cauteries, and other tools that differed little from modern instruments in form, though not in cleanliness or metallurgy. Physicians had urine flasks for examination, pulse-taking techniques, and not much else. They didn't use instruments extensively because their practice was based on humoral diagnosis and prescription rather than physical examination. The elaborate medical instrument sets of later periods didn't exist in medieval medicine. The simplicity of tools reflected the limited physical interaction that physicians had with patients and the theoretical nature of their practice. The seasonal variations that medieval medicine recognized influenced treatment recommendations. Different seasons had different humoral qualities. Spring was hot and wet, summer hot and dry, autumn cold and dry, winter cold and wet. Diseases that appeared in each season were attributed to that season's qualities. Treatments were adjusted to counteract seasonal influences. The bloodletting calendars specified which days and times were appropriate for bleeding based on moon phases and astrological factors. There was elaborate structure to this seasonal medical practice, but it was all based on incorrect theory. The actual seasonal variations in disease, more respiratory infections in winter, waterborne diseases in summer, had real causes that medieval theory didn't recognize. The professional jealousies between different types of medical practitioners created conflicts that sometimes harmed patients. Physicians claimed that surgeons were ignorant manual laborers who shouldn't be trusted with complex cases. Surgeons argued that physicians were impractical theorists who'd never touched a patient. Both groups attacked apothecaries for overstepping into diagnosis. Everyone attacked irregular healers as frauds. These professional turf battles were about status and income, not patient care. The result was that different practitioners didn't cooperate or share knowledge effectively, limiting medical progress, and sometimes leaving patients caught between competing practitioners. The palliative care that medieval medicine could sometimes provide shouldn't be dismissed entirely. Even if physicians couldn't cure diseases, they could provide some comfort through pain medications, opium, reassurance, and attention. The placebo effect of receiving care from a learned physician in impressive robes speaking Latin medical terminology had real psychological benefits. The dietary advice to rest and eat light foods helped some patients. The human interaction and reassurance that physicians provided had value even when their medical interventions were harmful. Some patients probably benefited from the social and psychological aspects of medical care, even though the physical treatments were worthless or dangerous. The religious aspects of medieval medicine were pervasive. Physicians and patients both believed that God ultimately controlled health and disease. Prayer was considered an important part of treatment. Wearing religious amulets, invoking saints, and receiving last rites were standard practices. Physicians saw their role as cooperating with divine will, not replacing it. The religious framework provided meaning to suffering and death that medical failure couldn't prevent. When patients died despite treatment, it was God's will taking them home. Medical failure. This religious interpretation of disease and death reduced the pressure on physicians to actually cure patients and may have prevented critical examination of medical practices' effectiveness. The preservation of medical knowledge through medieval period, despite its errors, meant that when scientific medicine began emerging in 16th to 17th centuries, there was foundation to build on. The anatomical texts, even flawed ones, provided starting points for better anatomy. The pharmaceutical knowledge, even mixed with nonsense, contained some genuinely useful remedies. The surgical techniques, even crude ones, evolved into better procedures. Medieval medicine was a necessary stage in development of modern medicine, even though it was largely ineffective and often harmful. The continuity of medical tradition, training, and literature created institutional framework that eventually produced scientific medicine. The specific medical texts that dominated medieval medical education included the Hippocratic Corpus, collection of ancient Greek medical writing, Galen's extensive works on anatomy and theory, Avicenna's Canon of Medicine, and various other Arabic and Latin texts. These works were authoritative. Challenging them was heretical to medical orthodoxy. The reliance on ancient authority rather than observation meant that errors persisted for centuries. When Renaissance anatomists began actual dissection and observation, they discovered that Galen had made errors because he dissected animals rather than humans. But these errors had been taught as fact for over 1,000 years. The medieval reverence for ancient authority was obstacle to medical progress. The professional advancement that ambitious physicians sought came through securing appointments as city physicians, court physicians to nobles or royalty, or professorships at medical schools. These positions provided steady income, prestige, and opportunities to build private practices among wealthy clients. The competition was intense because positions were limited and nepotism was common. A physician's success depended partly on medical reputation, but more on connections, social skills, and political maneuvering. The most successful physicians were those who cultivated noble patrons and positioned themselves in wealthy cities, regardless of their actual medical competence. The malpractice protections that physicians enjoyed were substantial. Medical guilds defended members against complaints, arguing that bad outcomes reflected disease severity rather than physician error. The difficulty of proving malpractice when medical theory itself was flawed meant few physicians faced serious consequences for incompetence. The legal doctrine that physicians should be judged by standards of their time and training protected them from liability even when their treatments were harmful. Only the most egregious frauds or obvious negligence resulted in prosecution. The lack of accountability meant that medical practice could continue killing patients for centuries without significant reform. The interaction between medieval medicine and Christianity was complex. The Church supported medical practice and founded hospitals, but also taught that disease could be God's punishment for sin and that miraculous healing was possible through faith. Some religious figures argued that seeking medical treatment showed lack of faith in God's healing power. Others argued that God worked through physicians and that using medical care was proper. The synthesis that emerged was that medical care and prayer should both be employed, treatment for physical aspects, prayer for spiritual aspects. This allowed both physicians and priests to claim roles in healing without direct conflict. The specific case of treating tuberculosis, consumption, shows medieval medicine confronting chronic fatal disease. Tuberculosis was common and usually fatal, killing perhaps a third of sufferers within 5 years. The disease caused progressive weight loss, coughing, bloody sputum, and debility. Medieval physicians diagnosed consumption as cold, dry imbalance and prescribed warming, moistening treatments. They recommended rich diet, eggs, milk, meat, rest, avoidance of cold air, and sometimes travel to warmer climates. These treatments didn't cure tuberculosis, but the supportive care and nutrition probably helped some patients live longer. The physicians couldn't cure the disease, but their advice wasn't entirely harmful for once, though it was expensive and only wealthy could follow it. The development of specialized medical knowledge in specific areas shows medieval medicine making some limited progress. Ophthalmology texts described eye diseases and treatments, including cataract surgery. Surgical texts describe techniques for specific procedures. Pharmaceutical texts compiled recipes and ingredient properties. These specialized works preserved practical knowledge even when theoretical framework was wrong. The specialization allowed some practitioners to develop genuine expertise in narrow domains: cataract surgery, wound treatment, herbal preparations, even though they didn't understand underlying disease mechanism. The medical consultations that occurred when difficult cases arose brought multiple physicians together to examine patient, discuss diagnosis, and recommend treatment. The consultations followed elaborate protocols with senior physicians speaking first and younger practitioners deferring. The discussions referenced classical authorities and humoral theory, but also considered patients' specific symptoms and history. The consultations demonstrated learned nature of medicine and reassured wealthy patients, but the collective wisdom was still based on wrong theory. The physicians might disagree about details, which humor was excessive, which treatment was optimal, but they operated within shared framework that was fundamentally flawed. The public health regulations that some medieval cities implemented showed practical understanding despite theoretical ignorance. Cities regulated slaughterhouses, tanneries, and other noxious industries, requiring them to operate outside city walls or in designated areas. They mandated street cleaning and waste disposal. They regulated food markets to prevent sale of rotten goods. During epidemics, they quarantined infected houses and isolated travelers from affected areas. These regulations improved public health even though the theoretical justification, miasma, corrupted air, was wrong. The practical observation that filth and overcrowding correlated with disease led to useful interventions despite incorrect theory. The medical ethics that governed physician conduct emphasized duty to patients, professional dignity, and maintaining standards. Physicians were expected to treat patients honestly, maintain confidentiality, and not take advantage of patient vulnerability. They should dress professionally, speak appropriately, and maintain professional demeanor. They shouldn't guarantee cures, since outcomes were in God's hands, but should offer hope and use their skills conscientiously. These ethical guidelines were similar to modern medical ethics in acknowledging physician responsibilities and patient rights. But the ethics didn't require effectiveness. Physicians could follow ethical guidelines perfectly while providing useless or harmful treatments. The patient experience of medieval medical treatment involved mixture of hope, fear, and resignation. If you were wealthy enough to afford physician, you hoped their learned knowledge and expensive treatments would cure you. But you also feared the treatments, bloodletting, purging, cautery, that were painful and weakening. You experienced the progression from diagnosis through multiple treatments to either recovery or death. If you recovered, you credited the physician and God. If you deteriorated, you blamed the disease or accepted it as God's will. The psychological experience of being treated provided some comfort even when physical treatments were harmful. The human need for healers was met even when the healing was illusory. The monasteries and convents that provided medical care to the poor operated infirmaries based on charity rather than profit. The monks and nuns who tended the sick had limited medical knowledge but provided basic care. Clean bedding, adequate food, prayers, and comfort. The monastic infirmaries sometimes achieved better outcomes than physicians because they didn't use aggressive, harmful treatments. The simple supportive care allowed patients to recover naturally from diseases they could survive. The religious framework emphasized care for the sick as Christian duty, creating network of charitable medical facilities even though they offered limited medical treatment. The traveling healers who moved between communities included legitimate practitioners, charlatans, and everything in between. Some were barber surgeons offering bloodletting and tooth extraction. Others were medicine sellers hawking cure-alls. Some were specialized practitioners like cataract couchers or hernia surgeons. They set up in market squares, performed demonstrations, and treated whoever would pay. The quality varied enormously. Some had genuine skills, others were complete frauds. The mobile nature of their practice made it hard to hold them accountable when treatments failed. They moved to next town before angry patients could seek redress. The medical libraries that accumulated at universities and in physicians' private collections preserved medical knowledge but also perpetuated errors. The most valuable books were elaborately illustrated manuscripts worth fortunes. A successful physician's library might contain dozens of medical texts, classical works, Arabic translations, contemporary treatises. The libraries represented investment in learning and professional status symbols. But the book's contents were mostly wrong. Humoral theory, astrological medicine, erroneous anatomy. The preservation of these texts ensured continuity of medical tradition, but also made it harder to break from ancient errors and develop new knowledge. The comparative life expectancy analysis suggests that medieval people who never saw physicians lived as long as or longer than those who received regular medical care. The wealthy, who could afford physician services, didn't live significantly longer than prosperous peasants who couldn't. The difference in life expectancy was driven by nutrition, housing, sanitation, and avoiding infectious disease, not by medical treatment. The physician's main contribution to wealthy patients' health was probably dietary advice promoting moderation and avoiding excesses, not their medical interventions. The inability of medieval medicine to extend life, despite its elaborate theories and expensive treatments, demonstrates its fundamental ineffectiveness. The psychological effects on physicians themselves from practicing ineffective medicine aren't well documented, but can be inferred. Physicians watched many patients die despite their treatments. They couldn't cure most diseases. They used treatments that caused suffering. How did they reconcile this with their self-image as healers? The answer seems to be through humoral theory and religious framework that explained failures as God's will or disease severity, rather than treatment inadequacy. The physicians who wrote about their practices don't express doubt about their effectiveness. They believed they were helping. This suggests either genuine belief in their methods or sophisticated self-deception that allowed them to continue practicing despite poor outcomes. The question of whether medieval people would have been better off without physicians has clear answer for most of population. Yes. The poor who couldn't afford physicians and relied on folk remedies, simple care, or nothing were probably better off than wealthy patients who received bloodletting, purging, and toxic medications. The aggressive medical interventions killed or weakened many patients who might have recovered naturally. The massive bloodletting that doctors performed on sick patients, sometimes removing pints of blood, caused shock and death in people who might have survived their illnesses. The expensive pharmaceuticals containing mercury and other toxins poisoned patients. The surgery without antiseptic technique infected patients. For most medieval people, the best medical advice would have been to avoid doctors entirely. The transition to scientific medicine required several developments: understanding of anatomy through systematic dissection, recognition that observation should test theory, rather than confirming ancient texts, development of scientific method emphasizing experimentation, discovery of circulation and other physiological processes, development of microscopy, revealing bacteria and cells, and eventual germ theory explaining infection. These developments took centuries and occurred gradually from Renaissance through 19th century. Medieval medicine was necessary stage in this development, but also obstacle that had to be overcome. The reverence for ancient authority, the elaborate humoral theory, and the professional resistance to change all delayed medical progress. The ultimate assessment of medieval medicine is that it was systematic, learned, expensive, and almost completely ineffective, while often the physicians were educated, well-intentioned, and confident in their methods. But their methods were based on incorrect theory and caused more harm than good. The surgical care provided some benefit in trauma cases. The public health measures helped during epidemics. The simple supportive care occasionally helped. But the core medical practice, humoral diagnosis and treatment through bloodletting, purging, and toxic medications, was worse than useless. Medieval medicine represents what happens when elaborate theoretical systems are constructed on false foundations, and when reverence for authority prevents critical examination of practices that don't work. The legacy of medieval medicine for modern medicine includes both positive and negative aspects. The institutional structures, universities, medical licensing, professional ethics, evolved from medieval foundations. The accumulation of medical texts and knowledge, however flawed, provided material that later reformers could build upon. The practical, anatomical, and surgical knowledge that developed, despite theoretical errors, contributed to modern surgery. But medieval medicine also delayed progress for centuries through reverence for authority, resistance to observation, and elaborate incorrect theory that had to be unlearned before real advances could occur. The centuries of bloodletting and harmful treatments represented enormous suffering that better medical practice could have prevented. The modern romanticization of medieval medicine as herbal healing and natural remedies ignores the reality of harmful practices and ineffective treatments. The popular image of medieval healing as gentle and natural compared to modern aggressive medicine is historically false. Medieval medicine was aggressive, bloodletting, purging, cautery, surgery without anesthesia. The herbal remedies that are celebrated today were minority of treatments, and many of them were ineffective or toxic. The few genuinely useful herbs don't justify the larger system that killed and harmed countless patients. Understanding medieval medicine accurately requires acknowledging both the sincere efforts of practitioners and the tragic ineffectiveness of their methods. The specific comparison between medieval physician treating fever and modern approach illustrates the revolution in medicine. Medieval physician examined urine, consulted astrology, diagnosed humoral imbalance, prescribed bloodletting and purging, and charged significant fees. Modern physician takes patient history, performs physical examination, orders diagnostic tests, blood work, cultures, imaging, identifies specific pathogen or cause, prescribes targeted antibiotic or treatment, monitors response, and adjusts treatment based on results. The medieval approach was elaborate ritual based on wrong theory. The modern approach is evidence-based intervention targeting specific disease mechanisms. The contrast shows how far medicine has advanced and why medieval practices were so ineffective. The question of what medieval physicians would think of modern medicine is intriguing. They'd be amazed by diagnostic technology, effective treatments, and extended lifespan. They'd struggle to understand germ theory, cellular biology, and biochemistry that contradict everything they learned. They might initially reject modern medicine as impossible or heretical. But if shown the evidence, microscopic bacteria, successful antibiotics, X-rays revealing internal anatomy, would they recognize their theories were wrong? Or would they try to incorporate new knowledge into humoral framework? The intellectual humility required to admit that everything you learned and taught was fundamentally mistaken is difficult but necessary for progress. Modern physicians should remember this when current medical knowledge is challenged by new discoveries. The survivors of medieval medical treatment, those who recovered despite harmful interventions, succeeded through robust immune systems and luck, rather than because of medical care. The human body's ability to heal itself from many illnesses and injuries meant that some patients recovered even after being bled, purged, and poisoned by physicians. The physicians took credit for these recoveries without acknowledging that patients might have fared better without treatment. The fundamental confusion between correlation and causation, patient received treatment and recovered, therefore treatment caused recovery, persisted because controlled trials comparing treatment to no treatment didn't exist. The few skeptics who questioned medical effectiveness were dismissed as ignorant of medical science. The historical recognition that medieval medicine was largely ineffective came gradually as scientific medicine developed in 18th, 19th centuries. The physicians who began using observation, experiment, and statistical analysis to evaluate treatments discovered that many traditional practices didn't work. The acknowledgement that bloodletting was harmful, that most pharmaceuticals were useless, that humoral theory was wrong. These realizations required overcoming centuries of tradition and professional resistance. The transition wasn't smooth, and many harmful practices continued well into modern era. But eventually, evidence overcame authority, and medicine began the transformation into effective, evidence-based practice. The lesson from medieval medicine for contemporary society is that elaborate systems built on incorrect foundations can persist for centuries, despite poor results, if protected by professional authority, tradition, and lack of critical examination. The medieval physicians were learned, confident, and socially respected, but they were fundamentally wrong. Their expensive treatments harmed more than helped. Yet the system persisted because it served social and psychological functions, providing structure for dealing with disease, employing educated elites, offering hope to patients. Modern societies should remember that current beliefs and practices, however confident we are in them, may be wrong, and future generations may view our certainties with the same skepticism we apply to humoral theory. Humility about current knowledge and openness to new evidence are essential for progress. The final reckoning of being a medieval physician is that you spent years learning elaborate, incorrect theory, practiced treatments that usually harmed patients, couldn't cure most diseases, watched helplessly as epidemics killed thousands, charged fees that impoverished families, maintained professional dignity while causing suffering, and genuinely believed you were healing people when you were usually making them worse. You were product of your time and education, doing what you sincerely believed was right. But from modern perspective, you were practicing harmful medicine based on false theory. The tragedy wasn't lack of effort or sincerity, but fundamental ignorance of disease mechanisms and physiology that made effective treatment impossible. Being a medieval doctor meant being confident and wrong, learned and harmful, respected and ineffective. A sobering reminder of how much medical knowledge has advanced and how much human suffering was caused by well-intentioned but fundamentally mistaken medical practice. So the next time you hear about medieval medicine, the learned physician studying ancient texts, the herbal remedies connecting with nature, the dignity of the healing profession, remember the reality, the humoral theory that was completely wrong, the bloodletting that killed patients by removing blood they needed to fight disease, the plague doctors in bird masks watching helplessly as a third of Europe died, the surgery performed without anesthesia or antiseptic technique, the urine examination that diagnosed diseases that didn't exist, and the understanding that medieval physicians with their university degrees and Latin terminology were causing more harm than the illiterate folk healers they despised. Remember that if you were sick in medieval Europe, seeing a doctor probably made you worse. Being a medieval physician meant practicing elaborate medicine that was almost completely ineffective while maintaining confidence that you were healing people. You spent years learning humoral theory, memorizing ancient texts, and studying astrology, none of which helped you cure disease. You prescribed bloodletting that weakened patients, purging that dehydrated them, and toxic medications that poisoned them. You performed procedures without understanding infection, without anesthesia, without any real knowledge of anatomy or physiology. You charged fees that bankrupted families for treatments that didn't work. And you maintained professional dignity and authority throughout, genuinely believing in your methods even as your patients died. The confidence and the elaborate rituals couldn't compensate for the fundamental ignorance of disease mechanisms. And so ends our journey through medieval medicine. If you enjoyed this exploration of reality behind the learned profession, subscribe for more journeys revealing historical truths. Leave a comment telling me which aspect of medieval medicine surprised you most, or suggest another topic you'd like me to explore. Sleep well, time traveler. And maybe tonight, appreciate that modern antibiotics can cure infections that killed medieval patients by the thousands, that surgeons use anesthesia so you don't feel every cut, that doctors understand anatomy from dissection rather than ancient texts, that diagnostic tests reveal what's actually wrong rather than diagnosing imaginary humoral imbalances, that medical treatments are tested to prove they work rather than being based on authority from texts written millennia ago, and that germ theory explains infection rather than attributing disease to corrupted air or divine punishment. Appreciate that modern medicine, for all its imperfections, is based on evidence and actually cures diseases rather than making them worse through confident ignorance. Sweet dreams.